Hello, everyone. So I would like to thank Team YOSI and the Ocular Emergency team for giving me this opportunity to share some insight on this dreaded ocular emergency of aggressive ROP or ARP and its management. So the International Classification of Retinopathy of Prematurity introduced the term aggressive posterior ROP or APROP, which is a severe variant of ROP and has a rapidly progressive course. That is, it does not usually follow a stage-wise progression of a classical ROP. The third edition of ICROP revised the terminology to aggressive ROP, removing the term posterior because it could also be seen beyond the posterior retina and even in larger infants. So usually the smaller infants with a birth weight of less than 1,000 grams or with associated systemic risk factors are at a greater risk of developing this variant of ROP. However, in developing countries like India, even the larger infants can also have aggressive ROP. So if we look at the clinical features, right from the anterior segment, if we look at the features of plus disease, you just need a 20D lens and an indirect ophthalmoscope to focus on the iris to see the iris engorgement of vessels or the neovascularization of iris. That you could also appreciate tunica vasculosa lentis as is shown in the image given. There could be pupillary rigidity, that is the pupil won't dilate even after multiple installations of dilating drops. There could be vitreous haze, and looking at the posterior segment or the posterior pole, we could appreciate dilation and tortuosity of the posterior pole vessels, okay, as shown in the by the white and the yellow arrows respectively. And also you can appreciate the AV shunts or the AV loops, which are marked with stars. So this is the left eye of the same baby. Again, you can appreciate the dilation and tortuosity of the vessels and the AV shunts or the AV loops, which are present in all four quadrants. Hybrid ROP is a variant of aggressive ROP, which has all the features of aggressive ROP along with a stage or a ridge, which is usually present at the borders of the vascular and avascular retina. So it's a mix of a classical ROP and aggressive ROP. So in the pre-anti-VEGF era, laser photocoagulation of the avascular retina was the primary modality of treatment even in aggressive ROP, and is still today used in some cases as a primary modality of treatment. Now, lasers in ROP are a bit different from the PRP which we do for diabetics. These are near confluent lasers done anteriorly up to the ora serrata. What we need to understand is laser takes time to regress these new vessels. So by the time the laser takes full effect, the disease may still keep progressing. More posterior the disease, it will need more extensive laser, and historically has shown more unfavorable outcomes with laser monotherapy. That is, the disease may not regress completely if the disease is more posterior. And also with the extensive amount of laser that we do in these babies, there is a severe constriction of visual field. And as you can see in the images given, there is only a small island of central retina which is remaining. So in the anti-VEGF era, where we have multiple options of anti-VEGF agents, which act within 24 hours of administration, and immediately in the first post-op day, you can see a decrease in plus disease. Important points to remember are that the dose used is usually half of the adult dose, and the direction of the needle while administering is parallel to the visual axis. The advantage is that it permits the peripheral growth of vessels. It avoids the extensive visual field loss. The most important point to remember is that there is a need for follow-up of these babies, because we need to treat the reactivation of ROP with either laser or repeat anti-VEGF injections. So here is an example of a combination therapy where the baby was diagnosed as a zone 1 aggressive ROP, treated with intravitreal ranibizumab. You can see the decrease in the features of plus disease in the second image. And by 7 to 8 weeks of administering the anti-VEGF agent, you can see there is peripheral growth of vessels, but now there is a stage with brush border new vessels, and which has subsequently regressed with a nice laser of the avascular retina. So even with the best of our efforts, and sometimes due to delayed presentations, the babies may progress to tractional retinal detachments, which we need vitrectomy. And historically, the surgical success rate in these cases is limited or often poor. So we need to catch them early, we need to treat them early, but it would be better, even better, if we prevent aggressive ROP with better NICU care. Thank you.